Thanks, Kelly. Good evening, everybody. I'm glad you were all able to make it, and I'm going to get my screen popped up here. And I just have a few slides to do to touch on kind of indications for why we would do DBS in patients, and then pass it on to Kyle Nelson to go through more details of the surgery itself, and then hopefully we'll have plenty of time for questions at the end. So I'm going to focus on Parkinson's and essential tremor as far as DBS therapy. Dystonia is another movement disorder that can benefit from DBS. It's just not as often performed, primarily because cervical dystonia, which we see in adults most commonly, would be more or well responsive to Botox and neurotoxin. So we would do that. And we've had one refractory dystonia case that had some good results with DBS, but again, Parkinson's and essential tremor is the bulk of the cases we're doing. So with DBS, it's deep brain stimulation. This is a high frequency stimulation that we apply to specific targets deep in the brain, which is how it got that name. And so one important thing would be update from past years is there's 3 companies that now have devices on the market in technology: Medtronic, Boston Scientific, and Abbott Laboratories. One other big change is that there's directional leads now within those devices, and so this can allow us within the target better programming capabilities to kind of stimulate the areas we want and avoid some of the side effect areas. So you can see by this demonstration how the lead without the directional would potentially spread into the internal capsule or brain areas that would cause unwanted side effects, versus if you directionalize a little bit, you're getting more within that target and avoiding some of those unwanted areas. So that's pretty new and has been cool in some areas to be able to program around some of the side effects that we wouldn't have been able to in the past. So that's a big advancement recently that I think has improved outcomes even more. So for DBS, specifically for Parkinson's, we're looking at people generally that have a good response to carbidopa-levodopa. The caveat to this is I've seen some really tremor refractory. So if they're real tremor predominant and either require really high doses of levodopa or multiple medications, or you don't really see even a good response to the tremor, but maybe they get some response with some of their rigidity or bradykinesia, but then start having dyskinesias with the higher doses, that can still, the tremor can still respond to DBS even when the levodopa is not fully treating it. So that would be the caveat to the responsiveness to carbidopa-levodopa that we like to see. And so when people start having, like usually in the first 5 years or so, you get a pretty good honeymoon period with the medications, and you might make some adjustments or add in different medications, but you're not having as much of those fluctuations that you see kind of mid stage or later stage into Parkinson's. So here's another graph that kind of shows where you have much more buffer as far as the ups and downs of the motor fluctuations earlier on in Parkinson's. And then as things progress, you get more times when you're either higher out of that window with dyskinesia or having off times that are not desirable. So outside of adjusting meds, the kind of introducing DBS as an option can be really beneficial. So that would be when you start getting more of these fluctuations and not getting good results in reduced off time with medication adjustments, a time to start talking about DBS with people. And I like to start talking about it kind of earlier rather than later, just to introduce the idea so that they're not taken too off guard with the idea of brain surgery, because obviously hearing about that is daunting at first, but kind of the more they struggle with symptoms and hear about it more or talk to other people that have had it, I think it can really start to be something that patients can consider and look into more. And so I usually have pretty in-depth individual discussions with patients about pros and cons and at what point should we do that. And here's a trial that the early Stim trial that led us to start doing DBS earlier for Parkinson's patients, because it showed that patients, 7.5 years in, if you took the DBS plus medication arm versus just medication alone, patients at 2-year follow-up did much better on their quality of life and UPDRS scores than the medication only group. And so that has led us to kind of start thinking about DBS as an option in Parkinson's patients earlier than we used to, where it used to be thought of as more of a later stage therapy. So effectiveness that you're looking for as far as what symptoms to talk to patients about, it helps tremor, as I stated. A common myth is that it only helps tremor, but it actually helps with bradykinesia, rigidity, dystonia. So I see a lot of younger patients with Parkinson's in their 40s, 50s that have more dystonia and rigidity or bradykinesia symptoms and not as much tremor necessarily, and they can respond really well to DBS. So it would be important to kind of acknowledge, the utility of DBS in those patients too, outside of tremor patients. And we see about at least 40 to 60% improvement in their motor scores with DBS, with again measuring the tremor, bradykinesia, rigidity, gait evaluation. Significant reduction in dyskinesias is often either with a combination of medication reduction or with the specifically globus pallidus target. We can lessen dyskinesias with the stimulation alone. You're looking at reduced off time by about 60%, and medications, we can usually in Parkinson's reduce the medications, but it's rare that we come off the medications altogether. So if they're looking for that, I try to temper their expectations. I have a few patients that can't tolerate any Parkinson's meds, and so then they're managing their symptoms with DBS alone, but that's pretty rare. Symptoms that wouldn't respond well would be significant postural instability. So if they have really hard time kind of staying upright, especially if it's when levodopa is working and they're still having a hard time with balance, then that's something that probably won't respond well or reduce falls in Parkinson's. Speech changes sometimes can respond, but there's often changes in speech that happen as part of the disease that don't respond well, or the DBS stimulation can have speech side effects that can be bothersome still. So that's something that I often make sure people aren't expecting, because we can get benefit, but it's not as clear as far as the benefit there. And non-motor symptoms, this is being studied more just to see if certain targets have some benefit on things like mood and sleep, and even bladder function, things that we haven't thought of as responding well to DBS in the past, but it's not clearly defined yet as far as what response people can get with the non-motor symptoms. And then of course, thinking and memory would not improve with this therapy. So along those lines, if someone has dementia, we consider them kind of not a good candidate, just because decision making as far as informed decisions as far as getting the surgery would be difficult, plus the benefit you're looking for from a motor standpoint would be overshadowed by their cognitive progression, and the surgery itself with going through the frontal lobes can bring on some cognitive changes, especially in that short term, that would be hard for patients with dementia to tolerate. And then being careful not to do surgery for atypical Parkinson patients, such as PSP, MSA, and then obviously dementia with Lewy bodies would come up with the cognitive screening, as those aren't well responsive to DBS. Other things to consider that we look for in the workup would be kind of comorbid psychiatric conditions, which would put them at higher risk for complications, disability that's high even in the on state. So if their levodopa is working and they're still struggling with their symptoms at those times, then they're probably not going to get the benefit you're looking for. If they have high surgical risk because of their other medical problems. Age is getting more fluid, especially as people are living healthier for longer. So we have several, like plenty of patients that in their upper 70s, even a few in their early 80s that have had surgery and done well, but we just proceed with more caution when patients start getting in the older age group. So it's part of our workup to try to figure out, are these people good candidates, and just making sure we have all the information and pieces to consider. One piece for Parkinson's is called OnOff Testing. So we do this in our program through a physical therapist over at Abbott Northwestern Courage Kenny site. And so we have a good setup where the patient comes in the morning. They have to be off their medication, so they do often need a caregiver or someone to be with them. And then there's the UPDRS motor scale that's done with video so that we can review it as a team. And then the patient takes a medication dose of some form of carbidopa, levodopa, and that test is repeated to see what their on score is. And we do like to see, or insurance likes to see, an improvement of at least 30%, just so you know, okay, their symptoms are responsive. And it just gives us good information about baseline disability and where they're at, and having the physical therapist there work with them at the time can give us some good insight about what their pre-surgical, post-surgical needs might be. So that's been really great to work with Courage Kenny on that portion of the testing. And then neuropsychologic assessment. So Susan Cohen, Maida Gunther, Amy Steiner through Naran, they've been great to getting people in timely for DBS workup to do that cognitive screen and mood. And then they also help assess just what kind of social support and other things the patient has that would impact how successful we are with doing DBS, because there's plenty of appointments before and after that people need to get to. So without good social or family caregiver support, that can really impact care. So then once those pieces of testing are completed, we do a consensus meeting, usually monthly, depending on numbers we have going through. And that has the physical therapist from Courage Kenny that did the on-off present, one of the neuropsychologists, Kyle Nelson, myself, and Kelly Melhorn is our nurse coordinator who is often present. So we review all the data, talk about where we would put the leads, device that which company we would like to use, and make sure we're kind of all on the same page. And then if everybody thinks that it's a good candidate, we'll refer, and they'll have an office consult with Dr. Nelson. So for essential tremor, the consideration's a little different, kind of less complex, because you're looking really just at the action tremor and how bothersome it is, and how much it impacts that person's quality of life. So here, I make sure we've tried all the medications if I'm seeing someone in consult for DBS, and then kind of do what we can medically, and have a frank discussion about what to expect with surgery. Patients can have a really profound decrease in their tremor. We do see a percentage of patients where they get an initial really good response, and then over the first few years, it kind of worsens sooner than we would expect, and then have a hard time getting control of it. So that's still a small percentage of patients where we can't get that good long-term control, but something that can be frustrating for patients and myself as the programmer. But I usually counsel people that if your tremor is at a point where you can't imagine continuing to try to live with eating and doing hobbies, that some people have hobbies that are really essential, or work, they're trying to keep working and they use their hands a lot, and then it's time to consider DBS. But sometimes I see patients and they're like, yeah, I have tremor, but it's manageable, adaptable. They don't necessarily feel like surgery is the right time, or ever, are not interested in ever doing surgery. So we have those discussions, and people are usually pretty receptive to that. The same contraindications you would look for if they have dementia. Again, something we wouldn't want to do surgery in those patients. consider their age and other medical problems. And then the workup here is more just doing the neuropsychologic testing, because of course you don't do the on-off, but making sure I have a good sense of what their tremor disability is and degree of tremor is before testing or before surgery is part of what I do in the office visit. So here's just an example of a spiral pre-surgery, and then after a programming session, the final. So people's writing can improve. You know, I have people kind of tearing up because they haven't been able to write their name legibly in so many years. So it's a pretty amazing therapy to be able to deliver to people. Here's a kind of workflow of how things would go. So you can refer to me as the movement disorder specialist, even if they're not sure, they just want to learn more about it, have a discussion. I'm happy to see whoever, unless they're obvious, like dementia patients or obvious not good candidates. Otherwise, I'm happy to see and evaluate and talk through things with people, even if they're not sure they want to be, or if you're not sure they're going to be a good candidate. And then depending on that consult and conversation, we'll set up the testing and then meet as a team. And then they would see Dr. Nelson in clinic and then have a surgery date and then the programming appointment scheduled a month out after surgery. So as far as the programming side of things, this is on the back end. Obviously, they've been through surgery, and then I'll see them a month out for their initial visit. And that's when the battery is turned on. And I try to explain to people it's not like just turning on a light switch. So their expectations are tempered a little bit, because sometimes people think it's just, oh, I just turn the battery on and they're good. So I make sure people know it's going to take several visits, usually several visits, to find the right combination of settings and then have them come back in and adjust things. But we have with the directional programming capability, and then now we're working with companies that can give us images that have the leads within the target. So it's post-op CT merged with the MRI, and we can get really cool images of the lead within the target, which has helped a lot with the programming, especially when you start trying to do the directional adjustments. Some questions that are pretty frequently asked would be, how long does it work for? For Parkinson's, we have good evidence going out 5 years, and there's more studies and things coming out showing benefit beyond that, up to 10 years or even more, as far as motor benefit, and then even quality of life benefit after that. Similarly with essential tremor, you can get that good long-term benefit with tremor control. And then again, with the medications, usually with Parkinson's, we can't stop the medications, and essential tremor, we often can taper off their tremor medications because they're not that effective in the first place, which is why we go for DBS. And here's our team, which we've kind of worked over the past several years to put a good team together. Have myself and Kyle Nelson, I think, collaborate well together, and DBS coordinator Kelly Melhorn, who helps with the nursing side of things and making sure patients have their questions answered and follow through from kind of start to finish. So she's over with Alina, and then Anushka is one of our program coordinators who also helps with education, and then doing on-off testing, big and loud treatments or therapy for follow-up after surgery through Courage Kenny, and then the neuropsychologist here at Naran that I mentioned. So with that, I will turn it over to Dr. Nelson. Stop my screen here.
Good evening, everybody. Thanks so much for joining us. I don't know if others have seen this presentation before, but as Dr. Rayek stated, there is some kind of new cutting edge technology that we have in DBS now that we haven't had previously. And I think it's always good to keep up to speed on those things. Most specifically, it's those directional leads that we have. Those have been really beneficial as she pointed out, in really contouring those stimulation curves into the area of treatment. And we've noticed some huge successes with those and really been able to push stimulation higher than we have in the past because of the ability to steer that stimulation. So I think those are really big keys. And then also some new advances in neuroimaging. There is some new technology that we've been utilizing lately that can identify the targets, STN or GPI, preoperatively, that we can then use not only for target localization in the operating room, but also for programming, knowing exactly where those leads are at after placement. So it makes programming that much easier. When you have the directional leads, we have many more combinations, obviously, now than what we had previously with just 4 contacts. And so sometimes knowing exactly which leads are in the sweet spot can be really helpful for that initial programming. What I'm going to do is complement Dr. Rayek's talk here with talking a little bit more specifically about the OR experience for these patients. Obviously, DBS surgery is a brain surgery. And it should be treated as such. It's a very high level, very precise surgery that we use to help these patients. And even though it doesn't seem all that invasive, I do consider it a full brain surgery, and it does come with real risks, which we'll talk about. So again, just to kind of touch a little bit on surgical indications. So we treat patients with Parkinson's disease, essential tremor, and dystonia, all with DBS surgery. They all have certain indications as far as who becomes a candidate, but as Dr. Rayek pointed out, I think those are pretty well defined. Most of the time, it's these patients that are medically refractory, meaning that they've reached the most benefit they can get out of their medications and either are having worsening side effects. Most often that's the dyskinesias with the Parkinson's medications, or they're continuing to have disabling symptoms from their disease despite full medical therapy. As you recall, often they get this cyclical pattern of having very short on times and much longer off times, which can be very debilitating to just normal everyday activities. And again, the push is for earlier surgery. That's for a number of different reasons. Mostly it's to really benefit those patients as long as we can. What we have found out about DBS surgery is that, given the equipment that we have, it can be a very long-lasting procedure. And so finding those patients that are right at that cusp or right at that tipping point of having difficulty with their medications can be a very beneficial treatment for them. And again, the more debilitated they get from their disease, the more challenges they have with recovery after a big surgery like this. And so I think treating them earlier when you still have some good control of their disease does rebound them quicker from a recovery standpoint. A couple of targets that we use for DBS, these really haven't changed much. It's classic STN and GPI for Parkinson's disease, and the VIM and the thalamus for essential tremor. Again, the targets have remained the same, but our ability to implant leads into these targets effectively and know where those leads are in the target has really changed. This is even within the last year. And so we are having a much better ability to place those leads safely and effectively and know where those leads are at in the targets. We do what's called a staged procedure for our DBS patients. It involves 2 different stages, 2 different surgeries, separated generally by about a week. The first stage is done awake, meaning that the patients come into the operating room, they're placed into a head frame, and all of the incisions and drilling and everything is done with the patients awake. Now, we do this to really check a couple of different things. Number one, we want to test those leads when they're actually in the brain. Obviously, these targets are very small, and so we want to make sure that when those leads are in the brain, that they're in the appropriate area. And so the best way to do that is clinically in the operating room. And we don't want to give them any kind of sedation medicine or anything like that that could skew those results. And so again, we've done hundreds of cases at this point, and I've had really good success with just doing this under local anesthetic. And I can't think of really a patient that we've had that we haven't been able to complete using this technique. So it does seem scary, and I do spend a fair amount of time talking to patients both in the clinic and preoperatively about this. But everyone comes to the operating room. In fact, the gentleman we just did on Monday said, well, that was a lot better than I thought it was going to be. So again, I think it's setting those expectations and having them understand the importance of doing this without any sedation medicine is really the key. Again, the goal of that first stage is to get both of those DBS leads into the brain. I would say the majority of our patients, we implant bilateral leads, both for essential tremor as well as Parkinson's disease. And the reason we do that is the majority of those patients do have bilateral disease. And so even though they may have one side that's worse than the other, implanting both electrodes at the same time generally is very beneficial to those patients. It really only adds about an extra 30 to 40 minutes onto the procedure to implant that second lead. And basically, we have everything all set up. So if they were to come back, it would be another procedure where we'd have to go through all these steps again if we were to do it in a 2 surgery procedure. That is one difference that we have compared to some of the other providers in the Twin Cities, is that we do implant bilateral electrodes. We also do it at a very efficient rate. Our placement of bilateral electrodes with microelectrode recording in a Parkinson's patient generally is about a 3 to 4 hour procedure, which most places are doing a single lead in that same amount of time. So we've created these efficiencies in the operating room, knowing that these patients are awake, knowing that this is a difficult time for them, to make sure that they get the best experience they can. Again, these patients come into the operating room off of their Parkinson's medications or off of their essential tremor medications, and can be in pretty rough shape. A lot of dystonias, a lot of tremor, and oftentimes that can be very debilitating for the patient as well. Sometimes can make surgery somewhat difficult if they have a lot of rigidity and stiffness as well. Anytime you're inserting something into the brain, you run the risk of hemorrhage. So I do keep those patients in the hospital for overnight stay after that stage 1 procedure. And again, it's mainly just to monitor them closely in case they were to have any side effects. We also get them started back on their Parkinson's medications, and just to make sure that they're tolerating that okay. The stage 2 procedure is done, like I said, about a week later. So after the stage 1, they have both intracranial electrodes in. Those are tucked underneath the skin. They stay overnight in the hospital, go home generally the next day. We get a head CT to make sure the leads are in an adequate spot, and then bring them back a week later. Now, this second stage is done as an outpatient, meaning that they go home the same day. This surgery is much shorter. It generally takes about an hour or an hour and a half. The goal of this surgery is to implant the extension leads and the pulse generator. That is done under general anesthesia, meaning they're completely asleep, and then, like I said, it's done as an outpatient, meaning they go home the same day. This is basically it's skin incision, so it's a very tolerable procedure. Most patients don't have any issues at all with that, and the risks are very low. Again, we have these new directional leads, and what the directional leads have is they have a solid contact both at the bottom and the top, and then the middle 2 contacts are broken up into 3 contacts each. And what that allows us to do is to, again, kind of steer that stimulation, one direction or another based on which of the contacts you're using to actually stimulate the patient. Really cool technology, and really has been very beneficial, especially in some of these patients that have really tough disease to treat and really need high stimulation, that sometimes you get some side effects from just their standard stimulation. I used what's called a frame-based system, meaning that patients are placed in a stereotactic head frame, such as the one pictured here on the right side of the screen. That is actually secured to the skull. And so our process generally is to get an MRI scan preoperatively about a week ahead of surgery. That it gives me time to plan trajectories. This is some of the planning software used here. It's called a Stealth Planning Station. It's made by Medtronic. and basically it's made specifically for placement of DBS electrodes. And so we're able to pick the targets and then pick trajectories of those leads going into the brain. And then using the stereotactic frame, able to identify where those targets are very precisely. That MRI scan preoperatively is merged with an intraoperative CT scanner. So we use something called an O-arm, which you'll see here on the next screen. So this is the O-arm here. This is an intraoperative CT scanner. So that's brought into the room. The CT scan is done of the head in the head frame, and then this is a stereotactic head frame here. So it registers that patient's head to the coordinates on that CRW frame. Then using the computer station, which is actually this piece right here, we're able to then get the XYZ coordinates for where those leads need to go. And then using that stereotactic frame, able to place those leads very accurately into the brain. This is a new piece of technology that we've had for probably about 4 or 5 years now. Before, what our workflow was is that we'd have to place the patient into their head frame in the pre-op area, actually go upstairs at Abbott Northwestern Hospital to the CT scanners, get a CT scan, and then bring them back down to the operating room and do the procedure. This has saved us about a half an hour to 45 minutes during our procedures just by utilizing this O-arm technology. So it's, again, really been a great benefit, really helping those patients get through this procedure as quickly as possible. As you can see here, the patients are in kind of a lounge chair type position. So it tends to be very comfortable, I would say, for the patient as much as it can be. And they're able, like I said, they're fully awake, so they're able to talk and see and ask questions and things like that during the procedure. We also keep them in this position so that we can test, which I'll show you here in just a sec, test some of their motor symptoms, bradykiniasias, rigidity, while we have stimulation on, again, to check the efficacy of the lead placement. Picture here on the right is sort of our formal setup. So here is a sterile drape that's placed over what's called a C-arm, which is an intraoperative X-ray machine. What we use that for is once the lead is placed, we take an intraoperative X-ray to make sure that that lead stays in its place while we're locking it down. Those leads are actually secured down to the skull. There's a small cap that we place over the burr holes or the holes in the skull that we drill. And then that cap is secured to the skull with small little screws, and then that lead is crimped into that cap so that it isn't able to be pulled in or out. Everything on this side of the drape is considered sterile, and everything on the other side is unsterile. And so again, just on the other side of this drape, the patient's fully awake, able to talk to us, answer questions, move their arms and legs, and participate in the procedure. What this picture is of here is this is our microelectrode recording machine. So before we place the leads into the brain in patients with Parkinson's disease, we'll actually stick a small little electrode into the brain, which we monitor the cellular activity as we go deeper and deeper into the brain, and actually have very characteristic findings, both in STN and GPI, that allow us to, again, verify that we're in the correct spot. What we're generally looking for is about 6 millimeters, 5 to 6 millimeters of good either STN or GPI, so we can get at least 2 contacts from that lead into those areas. Occasionally, if we don't see that, we'll move either medial or lateral, depending on the kind of where we find those targets and how much of the target we actually found. So a very useful piece of equipment, again, just to verify where those targets are that we're looking for. Once those leads are placed into the brain, Dr. Rehak generally is in the room for that, and she is able to verify the efficacy of those leads. So as you can see here, she's testing some bradykinesias of this patient, and then she also will look at rigidity and any tremor control depending on the patient's symptoms. Again, these patients are off of their medication, so oftentimes these symptoms that they have are exaggerated, and within seconds of stimulation, you can oftentimes see that rigidity melt away, see that tremor go away, and also see dramatic improvement of their bradykinesias. Again, this is, I consider this a major brain surgery, and that does not come without complications. Luckily, in DBS surgery, we have very low complication rates, but when we do have complications, they can be very catastrophic. Probably the most catastrophic is intracranial hemorrhage. As you can imagine, I'm sticking that lead into the brain, and all I can see is it entering into the cortex. I always, here in Minnesota, can relate this to ice fishing. You see the line drop into the water through your ice hole, but you don't know what's underneath that ice hole, and what kind of fish are down there. And so I don't know, as I'm placing that lead into the brain, whether or not it's causing any type of hemorrhage. Really, the only way to find that out is through a head CT postoperatively, or if the patient develops any symptoms during the procedure that would lead us to think that that's going on. Again, most of these hemorrhages that do occur, so I generally tell patients they have a 1% risk of hemorrhage with placement of bilateral DBS leads. Most of those hemorrhages are going to be silent hemorrhages or asymptomatic hemorrhages, meaning that we will see them on a head CT, but the patient won't have any symptoms. Again, most of the time, those will heal up on their own without needing any type of intervention. Occasionally, we will get patients with catastrophic or symptomatic hemorrhages. Here it says 1%. I generally think we've gotten a little better than that. It's probably less than 1%. But again, we've had patients that have passed away because of the significance of their hemorrhages postoperatively after placement of a DBS system. And infection is probably the biggest risk overall. Again, knock on wood, we have a very low infection rate. But again, I quote that generally to patients at about 1%. If you do enough DBS surgeries, you'll get someone that gets infected. The problem with an infection with DBS is because it's a foreign body, a lot of times that whole system needs to come out. You can't just treat it with antibiotics. So you go through all this procedure to get everything placed. And again, a lot of times you have to pull that whole system out, treat them with antibiotics, and then they would be a candidate potentially for placement again. However, most patients don't want to go through that if they've had that type of problem. Lastly, lead fracture, I would say, with the new companies coming into the market, both Avid as well as Boston Scientific, their products are very good products, well-designed products. Our risk of lead fracture nowadays is essentially zero. I don't think we've had a problem with that that I can remember since we started doing this 8 years ago. So the really good quality products, very easy for patients to understand if they need to do any programming. They've really done a nice job with working out all the glitches with that, and then also the recharging capabilities of some of the pulse generators. A couple of final thoughts. I think DBS surgery is a very safe surgery. Again, it's a brain surgery. It does come with certain risks, but I think overall, very safe surgery. Risk of a major complication is, in the single percentages. It's very effective. When you see patients who have had DBS surgery, oftentimes the only thing they say is, "I wish I would have done it sooner." It's not a question of, "Gosh, I don't know if I really get that much effect or a benefit from it," but they wish they would have done it sooner because that's how much improvement they get. And again, it can be life altering, especially some of these patients with essential tremor. They can go from not being able to feed themselves or drink coffee or play cards or go fishing or do any of these things that they really enjoy doing, and they can go back to doing that, and they are very grateful for that. A little bit about our program. Dr. Rayek and myself have spent a lot of time really building this program to what it is today. I consider this a very comprehensive DBS or movement disorder program. We have the capability of doing everything from preoperative evaluation to programming, including high-level neurosurgery. We've created a very efficient process. What our goal has been is to try and create a patient-centered experience, trying to get these patients through the preoperative evaluation process quickly, getting into the operating room quickly, and then getting them programmed. What in most academic institutions, which is where most of these surgeries occur, that pre-op evaluation process can be anywhere from 6 to 9 months, sometimes a year, depending on how quickly they can get patients in for on-off testing and neuropsych evaluation, and then also surgical implantation. We're trying to do that in generally about 3 months, which in COVID times has been a little bit more of a challenge. But I do feel back in 2019 kind of was really when we were getting this going, and we were actually having very good success. So from the time a patient decided they wanted to proceed forward with surgery till the time they saw me and we were getting them set for surgery, we were doing that in about 3 months, which is really remarkable. And then again, surgical implantation. Like I said, I've done a lot of work working with the OR staff to make this as efficient and good experience for the patients as we can. Obviously, it's a very stressful time. They're having open brain surgery and they're awake during the whole thing, so it can be very very stressful. But I think patients are able to get through it, and I think a lot of that is because of the time and effort we've put into building this. I always tell patients, expect it to be like a NASCAR pit crew when you get there. Everyone has their own job and everyone knows what to do, and there's going to be people kind of running around and people coming in and out, but that's all to make sure that things are going efficiently. And again, I'm really proud of the OR staff and what we've been able to accomplish. Being able to implant bilateral DBS electrodes with microelectro recording in 3 to 4 hours is really remarkable, and really second to none in my opinion across the country. We have multiple locations where we see patients. Obviously, Dr. Rayek sees patients in Blaine and West Health, and then also down in Minneapolis, as well as now with telemedicine, can see patients really anywhere. I also have multiple locations where I see patients, and so it makes it a little bit more efficient for patients to come in and out, especially outstate patients that are coming in or driving any distance and don't like to go all the way down into Minneapolis. You can see them at some of our other satellite locations for the pre-op and post-op evaluations, and also some of the programming. Again, we have monthly multidisciplinary consensus conferences. I think those are very effective. We're able to get a lot of work accomplished in a very short amount of time and able to really give patients the best treatment using the best products that we can. And we do implant all the products. I would say we implant a little bit more Medtronic in Boston than we do Abbott, but are able to implant all the products, and I think they're all really good products. But we have our own preferences, mostly from a support standpoint as well as programming standpoint. I would say we have excellent results. I think we could match our results to anybody across the country, and we would have as good or better results than them. And again, part of our program is getting out and educating some of these patients. In my opinion, Parkinson's patients, a lot of them are part of really big, broad support groups. We do very similar events like this with them, and I find those very effective and very welcoming to the patients and their families. And so we do these generally about quarterly. I think Kelly has sent out and we'll be continuing to push some of our events for 2022. We have quarterly events scheduled for 2022 already that we would be happy to have any of your patients come to. Again, just even to hear more about the possibility of DBS. They don't have to sign on the dotted line after we give the talk, but I think it's important for them to hear this, especially if they're serious in DBS, because a lot of what I talk about in clinic is the same stuff we talk about during these presentations. And so anytime you can hear something more than once, it sticks a little bit better. Again, a number of different contributors to our DBS program. Again, we've worked now, I think Kelly Melhorn is our newest member, and she's been around for about 2 years now. So Dr. Rayek and myself have been doing this for 5 or 6 years. Anushka's been with us for almost that whole amount of time, as well as Courage Kenny. So we've got a really established program, really helped a lot of people, and have really made some great efficiencies to get patients in and out of this system. Questions always come up on how do we get patients into your program. As Dr. Rayek stated, she's happy to meet with anybody to see if they'd be a candidate for DBS or just to educate them a little bit about it. I think everyone has patients in their practice that may have some of these diseases that may be at the tipping point of needing surgery, and we'd be happy to talk to those patients and invite them to our educational events so they can learn more about the process and see if they'd be a good candidate. Again, we are able to do full evaluation with preoperative testing. You don't have to worry about doing any of that. We have the capability and ability to do all of that. The other question comes up with, what happens to those patients? So if I refer those patients to you, do I just lose them? Are they gone forever? Or is there some ability to get those patients back into your practice for follow-up? And, we are able to provide all services if need be, but also very willing to work with individual neurologists as far as, giving them, allowing them to participate in the care of those patients. And so, we are able to take those patients on, do the preoperative testing, do even initial programming if need be, or do DBS adjustments, but then send those patients back to their primary neurologist for continued follow-up. We've done this very well with a number of different groups across the state, actually, and able to see those patients back, or now even do telehealth visits with those patients to kind of fine-tune them a little bit in their programming to make sure that they're getting the optimal treatment out of their DBS. And again, we're definitely able to take those patients' care over if need be as well. And some neurologists are just say, I've got them to this point, and I feel that they need to be in more of a specialist's hands, and are willing or wanting to just pass those patients on, knowing that they're going to get the best treatment that they can. And again, this is just open communication between myself and Dr. Rahek and the primary referring neurologist to make sure everyone's expectations are met. That's all I have. Again, I appreciate everyone joining us tonight. We definitely stayed on time here, so we do have about 6 or 7 minutes if we want to do some questions, if anybody has any questions. Otherwise, again, I appreciate you spending your evening with us to learn more about our DBS program and some of the new technologies that we have at our fingertips that have really been great for our patients. And even when I thought DBS was as good as it could get, we found that it could actually be better. So.
If anyone has any questions, you're welcome to unmute yourself and ask, or you can always type it into the chat feature at the bottom of your screen. Okay, then I guess, sorry, go ahead.
I was just going to say that a common question patients often ask is insurance coverage, which Dr. Nelson's office handles usually, but have not had significant problems with getting coverage. Is that right?
Yeah, and most of that is because of our preoperative process. We do all of the aspects that most insurance, either private or Medicare or Medicaid patients need. We do all of that, the on-off testing, the neuropsych evaluation. Those are really the key pieces that the insurance companies want to see prior to approving any of these procedures. But we've had some issues with Abbott Northwestern being in network for some patients, but we've actually been able to get those cases, get in-network benefits for some of those patients that had out-of-network or had Abbott Northwestern as an out-of-network hospital. Again, because of the specialty level care that we provide and how we do things a little bit different than some of the other systems.
Do you need an MRI, Eleanor, before seeing them, or you can order whatever you need?
Yeah, I can usually order whatever I need, because if they've had an MRI at some point in the course of their illness, then they get a pre-surgical one. So I often don't do one and then have them have to have another one, right, within a month after that. So it's okay if they have not had one recently.
Okay.
For them. Yeah.
And we take care of doing all that preoperative evaluation and getting the MRI scan scheduled and everything like that. So, it's like I said, we have a really great process in place and a lot of great support, both from the Moran Clinic and my office, as well as Alina, to make sure that these patients smoothly go through the system.
Yeah, if they've never had an MRI, I would say that would be good to get one, especially if they have like vascular risk factors or other things for potentially.
Well, it says that I'm sending you someone that I saw today, and then I didn't know if you wanted the MRI or just wait till they see you when they connect with you, or
Yeah, I can just do that as part of the workup if they have it. Yeah.
And sometimes I like to see that preoperatively as well. If they have a lot of brain atrophy, It does increase their risk factors just a tiny bit, especially bleeding risk factors. But again, it's not an absolute contraindication, but it's nice to know so you can have those conversations with those patients preoperatively.
Yeah.
And then battery life is another question, like how often patients need to get a battery change. So there's rechargeable batteries, especially through Boston and Abbott with their newest one that are 15 years. Medtronic has a rechargeable that's also 15 years, and that's not the newest battery. So their newest one that has some brain sensing capability is a non-rechargeable that's about 3 to 5 years as far as battery life. I think we've covered anything else?
Anyone else have any questions? All right. Well, thank you, Dr. Orayak and Dr. Nelson.